All right, I'm going to go ahead and get started here, guys. This is the third lecture in the kind of PFT series. This is about restrictive lung disease. No disclosures. So once again, I'll open up by talking about lung mechanics and the situation of restrictive lung disease, and then go into some detail about the four major categories that result in restriction, and finally treatment options for many of these diseases. So unlike obstruction, which is a problem with the airways, ventilatory restriction is a problem with lung parenchyma, respiratory muscles, or the thorax itself. And as you can see, normal inhaling and exhaling here, diaphragm contracts during inhalation. During exhalation, it relaxes, forcing the air out of the lungs. If there's any problem with the structures, the pleura, the diaphragm in terms of its muscle strength, or the lungs themselves in terms of their compliance, you're going to end up with less total lung capacity, and in some cases, less tidal volume, or a higher fraction of dead space in your tidal volume due to the lower lung volumes. And you can see it here on the graph, what a restrictive flow loop looks like. This is an expected normal, this triangle here, and you can see that normal volume is higher, and this is spirometry once again, so you have to measure total lung capacity to confirm a diagnosis of restrictive lung disease, but this one is suggestive of it. And you'll have generally reduced FEV1 and FVC in patients with this abnormality on spirometry, though the ratio of the FEV1 to FVC will be preserved. Here's another way to look at total lung capacity here, and you can see the normal right here. Your vital capacity is everything that you can possibly inhale to maximum or exhale to maximum. Your normal tidal volume lies as a smaller fraction somewhere in the middle there, and then there's the residual volume that can't be exhaled. For folks with restriction, you have a lower total lung capacity, and as a result, your vital capacity is also restricted. And these patients tend to have similar expiratory reserve volume and tidal volume to patients with normal lung physiology, though they have smaller residual volumes and smaller inspiratory volume that they can take in with effort. So as a result, patients with restrictive lung disease are at rest generally okay unless they have parenchymal lung disease that causes shunt physiology. But when faced with any kind of exercise, they become quickly unable to oxygenate very well due to the limited ability to expand the tidal volume and the limited ability to have lung expansion and reach a higher total lung capacity. This is in contrast to COPD. This is a patient with air trapping where you see a huge residual volume, but actually a relatively normal looking distribution of lung capacity, of vital capacity, tidal volume, expiratory reserve volume. And then neuromuscular weakness, total lung capacity is in quotes here because if the patient is given positive pressure, their lung compliance is great. But with the diaphragmatic weakness, their functional total lung capacity under their own effort is decreased, and you get a volume distribution that looks very much like mechanical restriction. So smaller lung volumes cause hypoventilation. And an important point here is that when lung volumes are smaller, the dead space ratio, which is represented by this equation, becomes higher. So the dead space, to review, is the oropharynx, the large airways, every part of the respiratory system that doesn't participate in oxygen onloading or carbon dioxide offloading. And so that represents a % of each tidal volume that is inefficient, if you will. And so for smaller lung volumes, that dead space doesn't change. If you're taking shallower breaths, you still have the same airway structures, but the tidal volume decreases. So when this ratio goes above 0.25 to 0.3, every breath becomes less efficient. So your functional minute ventilation is going to be lower at the same respiratory rate. So patients with restrictive lung disease are often tachypnic as the initial compensation to increase their minute ventilation and ensure that they maintain oxygenation and a normal pH. Another way to look at this is the alveolar gas equation, and notice the PaO2 is related to not only the FiO2 and atmospheric pressure, but also the PaCO2, which really represents how much oxygen is leaving the alveolus. So patients that become hypercapnic from hypoventilation will actually have a lower PaO2. And so when the patient is hypoventilating, you'll have an increased PaCO2 and P_CO2, meaning in the alveolar space and in the circulation, and the PaO2 will be decreased. So patients with restrictive lung disease, even if they don't have true shunt from interstitial problems, they will become hypoxemic just due to the fact that they're hypoventilating chronically. And you see this very often in patients with obstructive sleep apnea and obesity hypoventilation syndrome overlap with chronic hypoxemic respiratory failure. In addition, the low vital capacity really encourages atelectasis. If you can't expand your lungs with effort maximally, you're going to end up with areas of atelectasis, and this further compounds the hypoxemic problem. And we've discussed shunt before in previous lectures. You have collapsed alveolar spaces here, and blood from the pulmonary veins is not, or pulmonary arteries is not getting across through to the pulmonary veins with oxygenated blood, and as a result, you have a decreased PaO2 going back into the left heart and the systemic circulation. And a final point, and really how this atelectasis develops, is this concept is called the critical closing volume. This is the pressure at which the very small airways don't reopen during an inspiratory effort, or don't stay open in the sense or in the circumstance of normal tidal volume. So this patient that has restrictive lung disease, the place, if you will, of the tidal volume in the diagram that we saw earlier occurs at lower lung volumes, and you run into this critical closing volume where you have dynamic collapse of the small airways at end expiration. And this impairs mucociliary clearance and cough, and can lead to a situation like chronic bronchitis. It can lead to atelectasis and further compound the stress on the respiratory system that this patient is facing. So how do patients with restrictive physiology maintain oxygenation and pH? So they increase their minute ventilation with tachypnea. So if minute ventilation increases and dead space remains the same, alveolar ventilation goes up. So many of these patients will start compensating with tachypnea, and that very quickly leads into what's perceived as exertional dyspnea, because the patient's metabolic reserve and respiratory reserve is relatively low. These patients will also desaturate more quickly because they have less pulmonary and often cardiac reserve for oxygen delivery. The other compensatory mechanism is bicarbonate retention. Patients with restrictive lung disease also tend to retain carbon dioxide because of this hypoventilation. And if they're oxygenating well, the compensatory mechanism at this point is to retain bicarbonate, because remember, I go over this again in every lecture because I like the concept and it's very applicable to ICU medicine. Number one priority of the brain, heart, lungs is oxygen delivery. Number two, throw the kidneys in there, they do a little work, is to maintain a normal pH. And so if option one is met, they're oxygenating well, but the PaCO2 is higher, their response is going to be bicarbonate retention and a chronic compensated hypercapnic respiratory failure. So this is the end result of restrictive lung disease over time. Respiratory failure, which is what we like to talk about a lot in these pulmonary lectures, because respiratory success would be less interesting. And that's right, it's expected. So just some book definitions here. For hypercapnic respiratory failure is a PaCO2 over 45, and it's often durable in patients with the disease processes that we're talking about and progressive. Hypoxemic respiratory failure is PaO2 less than 55, and this in chronic, once again, is pretty durable and related to, in patients with interstitial lung disease, alveolar loss and shunting and inflammation, and in patients with respiratory muscle disease, thoracic cage disease, due to that alveolar hypoventilation concept with a high dead space fraction. Any questions about the mechanics part? So interstitial lung disease involving the lung parenchyma is a broad description of extremely many pathologies with different causes, different treatments. It's beyond one lecture on its own, so I'm going to speak in generalities for this lecture that really is focusing on the physiologic consequences of the problem rather than the specific pathology and therapy. But to give you a broad view of interstitial lung disease, most of us think about the IPF folks, idiopathic pulmonary fibrosis. And these idiopathic disorders here are grouped together and often cause restrictive lung disease. Some of them can also cause obstructive physiology. And the main differentiators in these idiopathic disorders are patients with IPF or a UIP pattern, usual interstitial pneumonitis, are patients with alveolar destruction and scarring that's fixed. This is opposed to the NSIP, nonspecific interstitial pneumonia, which is a more inflammatory process. You'll see ground glass opacities rather than interstitial fibrotic changes, and these are often associated. They're no longer idiopathic if you connect them to a rheumatologic disease, but they're often associated with rheumatologic diseases and respond to medical therapy. And then finally, the great mystery of sarcoidosis, which can look like anything and cause anything, will cause a spectrum of disease that can look like an NSIP, an IPF, or anything in between. Exactly, but you never know. Connective tissue and autoimmune disease very often cause inflammatory changes in the lung parenchyma, and these are supported by findings in other organ systems or laboratory studies that show antibodies to certain protein moieties, I like that word, that are circulating in the body or on cells. And these often cause subacute respiratory failure that goes along with other systemic problems. So when somebody is identified as having restrictive lung disease and has interstitial lung opacities, you've got to make sure that you do a complete workup for connective tissue and autoimmune disease, because this is among the more reversible of these kind of lung injuries. Occupational and environmental exposure, asbestos being kind of the classic one that shows up on tests, though I think most of the patients that have true asbestosis are probably dead by now. Have you guys seen any asbestos lung before? Yeah, I mean, I stopped seeing them about 8 years ago. So I think there's occasionally going to be sporadic exposure to asbestos, but until it goes away from the tests, keep in mind that it's the primary occupational environmental exposure that is associated with restrictive lung disease. You see the classic pleural plaquing, which in and of itself doesn't cause any problems. There's patients that have asbestos plaques but no ILD. The ILD associated with asbestos is very much looks like an IPF. There's a lot of fibrosis, a lot of scarring, a lot of bronchiectasis. They do. And especially with tobacco smoking on top of it, the risk of lung cancer is like 700 times the normal population. You'll see farmer's lung with organic dust that has an overlap with hypersensitivity pneumonitis. You'll see, coal, black lung from coal, etc. You can have more acute exposures that cause ILD, chlorine gas, for example. And then radiation pneumonitis is another one to think about in patients that especially have had radiation therapy for either mediastinal malignancies or breast malignancies. Drug-induced is a broad category that is, once again, important to rule out when you see parenchymal changes with restrictive lung disease, because many of these can be reversible as well, some of them simply by withholding the offending agent, and others with steroids or time. And drug-induced ILDs, main ones worth remembering are amiodarone toxicity, which can occur acutely or chronically, as well as many chemotherapeutic agents. And a lot of the newer chemotherapeutic agents that are monoclonal antibodies can cause idiopathic drug-induced interstitial pneumonitis. Antibiotics, macrobid is one that will come up occasionally as being associated with ILD as well. Infections, viral and bacterial infections that lead to lung scarring can result in ILD. You'll see this in the post-COVID syndrome very frequently. I think there's a guy in the ICU right now with a post-COVID syndrome, and his lungs are made of fibrosis now, so he has a chronic respiratory failure that's exacerbated by everything. And genetic and inherited. Anybody know what Hermansky-Pudlak syndrome is? I don't either. Good. So this interstitial thickening and fibrosis will lead to alveolar and capillary loss. And when you lose the circulation and the alveolar space, but don't actually lose the airways that go to that alveolar space, you're going to be increasing your dead space fraction, and that will result in alveolar hypoventilation. That's what I said. And it falls into these categories here. When you have, complete fibrosis, no circulation, this is true alveolar dead space. And when you have impaired circulation, you can have a relative dead space. And I really like this diagram because the entire lung is a parallel circuit of airways and blood vessels, with all of these things occurring at certain proportions within the lung, where most normal people have C, D, and E everywhere. And then you end up with a nice spectrum either towards one or the other if you're dealing with shunt or dead space problems. So in addition to parenchymal problems, pleural thickening will also lower inspiratory capacity. And the CT scan that you see here is somebody with a UIP pattern of interstitial lung disease. You can see along the pleura these kind of double rows of little honeycomb areas of scar. And what this does, in addition, this patient, you can see interstitial thickening as well pretty prominently. Lung compliance is lower. And also, if the pleura is fixed at any point, that's going to limit the ability of the lung to expand and limit lung compliance, resulting in lower vital capacity and restrictive lung disease. So pleural injury tends to go hand in hand with a lot of the ILDs, the idiopathic ones, and the rheumatologic ones, because they get significant serositis and eventually end up with fibrotic change in the pleura. So when thinking about pulmonary fibrosis, the initial presentation is often insidious cough and exertional dyspnea. Very early in the disease course, these patients will come into the primary care office and say, "Doc, when I walk my usual half a block to the mailbox and back, I'm starting to get short of breath. I'm thinking about not making that walk anymore." You say, "Are you coughing?" "Well, yeah, all the time." Dry cough, non-productive. And so some findings on further interview are going to be, if you're thinking about rheumatologic disease, synovitis, rash, erythema nodosum, fine inspiratory crackles is a pretty good physical exam finding for patients with ILD. You won't get those usual kind of wet expiratory and inspiratory crackles that you hear with volume overload. It almost sounds like a fine Velcro. Clubbing is associated with many ILDs. Social history, you want to get a history of tobacco use, occupational exposures, and then finally, you get the whole gamut of studies here. If you have a high suspicion of interstitial lung disease based on your history and physical, it doesn't hurt to go straight to a non-contrast CT to get a good picture of the lung, especially if you have a patient who falls into the category of needing screening for lung cancer anyways, based on tobacco use. You can kind of get all your information with one study there. This is black lung from Cole. Any questions about that part? So the neuromuscular diseases that result in diaphragmatic weakness will present either in the case of like ALS as a chronic progressive respiratory failure, or in something like Guillain-Barré, a pretty rapidly progressive respiratory failure. So this restrictive lung disease can present acute or chronically with these neuromuscular diseases, and really the rate of progression of hypoventilation can give you diagnostic clues to separate neuromuscular weakness from other causes of hypoventilation. I like to think of neuromuscular disease anatomically because these are all the places where the diaphragm can go bad. So muscle disease, myositis is a very common one, dermatomyositis, inclusion body myositis, that will affect the muscle itself. Neuromuscular junction diseases, myasthenia gravis being the most common of these. And always keep botulism and tetanus in mind. These like to show up on tests. These don't like to show up in real life. Lambert-Eaton is always worth thinking about in a patient with known lung malignancy, though Lambert-Eaton syndrome can precede the diagnosis of lung cancer by months or years in some cases. Peripheral nerve to the diaphragm compromise in the case of phrenic nerve injury, post-op patients with hemidiaphragmatic paralysis, post-cardiac surgery, I should say, will often develop a restrictive lung disease, and Guillain-Barré being kind of a rapidly progressive peripheral nerve problem. Multiple sclerosis can occasionally affect phrenic nerve function. And then finally, spinal cord injury, whether it be tumor, transverse myelitis, or trauma that cuts the cord function at a certain level, being C3, 4, and 5, can impair diaphragmatic function. Oh, look, I did some PowerPoint magic there. Okay. ALS is another one worth thinking about for spinal cord as well. And it has, its own typical physical exam and history findings that'll be able to make that diagnosis. So this disease is rarely isolated to the respiratory muscles, and that's important because other physical exam and laboratory findings will help you make the diagnosis. This is an inclusion body myositis. You'll have an elevated CK aldolase with this. EMG testing can help you differentiate myasthenia from Lambert-Eaton, for example. And this is what a diaphragmatic hemiparesis looks like. This is full inspiration. This is full expiration. So this patient probably had cardiac surgery and they got a hold of the left phrenic nerve. The specific PFT findings in neuromuscular weakness are, because we're talking about it, restrictive ventilatory defect, but also a decreased mandatory voluntary ventilation. So this is the test where you instruct the patient to breathe as hard and as fast as they can. And the maximum voluntary ventilation here is about equal to FEV1 times 40 in normal patients. And it'll be decreased in neuromuscular weakness because the patients will be either unable to have enough diaphragmatic strength to take large breaths, or they'll have the fatigability that you see with myasthenia gravis. Another finding that you can find is paradoxical breathing when supine. Patients, especially with diaphragmatic paralysis, have a lot of trouble breathing when flat because it takes away all of the mechanical advantage of being upright and using your accessory muscles to help with the inspiratory effort. And instead, the patient tries to use their abdominal muscles to augment their respiratory function. In patients with diaphragmatic paralysis, similarly, being submerged in water takes away that mechanical advantage. So very occasionally, you'll have people present with diaphragmatic weakness saying that when they get in the pool, they feel like they're suffocating. And with neuromuscular weakness here, there's a decrease in chest wall and lung compliance, increased work of breathing, vicious cycle of decreased muscle strength, and then ultimately that decrease in tidal volume and ventilation that cause the chronic respiratory failure syndromes that we talked about at the beginning. With neuromuscular disease, keep in mind that bulbar symptoms are often present, and these patients can have aspiration pneumonitis and aspiration pneumonia that complicates these issues. Scleroderma being one that you very commonly have both interstitial lung disease and chemical pneumonitis from problems with swallow function. So if you see somebody with lungs that look like this and neuromuscular symptoms, swallow eval is extremely important because ongoing injury to the lungs from aspiration events can lead to bronchiectasis phenotypes that we talked about in the last lecture. Thoracic cage abnormalities also change diaphragm mechanics and limit vital capacity. This is your kyphotic grandpa that you very commonly see with restrictive lung disease. He goes in at age 75. He quit smoking 40 years ago. He says, "Doc, I can't breathe." Primary care doctor says, "Well, clearly you have COPD. Here's some inhalers." He doesn't get better. This is where full pulmonary function testing, spirometry, total lung capacity are important in making these diagnoses because this guy may benefit more from nightly positive pressure ventilation than from any bronchodilator. This is somebody with scoliosis that has altered respiratory mechanics and may also need non-invasive ventilation at night because when patients with thoracic cage abnormalities are up and about, they can often compensate for their smaller lung volumes with accessory muscle use and increase in minute ventilation. But when they sleep and all of the muscles relax, they can end up retaining carbon dioxide and getting almost obstructive sleep apnea, obesity hypoventilation syndrome phenotype in terms of the interaction between the heart and lungs. Yep. And that's why for folks with scoliosis it's important to intervene when they're pediatric, because then the bones can heal in a more straight alignment and avoid these problems down the road. Here's another, this is kind of old school, we don't do this anymore, but thoracoplasty for tuberculosis. You see they took out a chunk of the chest wall here and the lung, just cut that tuberculosis out, it goes away. It's not a terrible idea, especially before you have quadruple drug therapy. This patient obviously is going to have restrictive lung disease. They have thoracic cage abnormality, they have less lung in there. I just like this x-ray. Look at how close the ribs are together. I mean, this lung probably doesn't even do anything. And cerebral palsy is a group of patients that you'll see restrictive lung disease, especially because the spasticity causes spinal deformity over time. And, you know, as you can see, there are some surgeries to palliate this problem earlier in life. But with cerebral palsy patients, rather than those with different causes of scoliosis, they don't respond as well to surgical therapy because it's an ongoing problem with spasticity during their entire life. So chronic respiratory failure from thoracic cage abnormalities, as I said, is very similar to OSA, OHS. They're going to have the daytime somnolence, morning headache, apneas during sleep that are really would make you think about obstructive sleep apnea. The difference being you get imaging or you diagnose a neuromuscular disease and you're able to say, hey, maybe this isn't obstructive sleep apnea. And really the key diagnostic points for these thoracic cage problems are a chronic hypercapnic respiratory failure and severe restriction on PFTs, which in spirometry is FVC is less than 50% of predicted. And that's going to correlate with the total lung capacity on the full PFT. A thoracic cage abnormality that usually doesn't cause problems is pectus excavatum. And there's tons and tons written on this because these patients tend to present with exertional dyspnea and atypical chest pain. Many of them do. And it's a complicated kind of neuropsychiatric problem, actually, because the way that the pectus excavatum affects the receptors in the lung that tell you, hey, I'm dyspneic, and also the looking at yourself and saying, man, my chest is caved in. These patients often will present with dyspnea on exertion, but have completely normal PFTs, completely normal labs, and many of them with cognitive behavioral therapy, those sensations will go away. And also many of them want it fixed for cosmetic reasons. And once that fix is in place, the patients no longer have dyspnea. So this is a kind of an interesting side case that you may see in primary care a fair amount, maybe more so in the pediatric population, but somebody with pectus might make it to you guys and say, I'm short of breath. Just don't say, hey, it's asthma. Here's an inhaler. Think about it. Any questions about that part? So obstructive sleep apnea and OHS, beyond the morning headache, daytime somnolence, this actually has metabolic consequences that are beyond what occurs in the other causes of restrictive lung disease. So this guy's name is Pickwick Peppers, and Charles Dickens wrote about him. He's the fat boy. So people knew about this Pickwickian syndrome, or obesity hypoventilation syndrome, as we now have to call it because we're #woke in 2021. No more Pickwick. He's gone to sleep again. Be good enough to pinch him, sir, in the leg, if you please. Nothing else wakes him. So this guy is obviously having some obstructive sleep apnea, falls asleep during the day, but I do like his coat and boots. Yeah, he's great. So sleep apnea is a result of mechanical obstruction of the airway during sleep. And this can occur in people that don't look like our friend, Mr. Pickwick, but very often does. So risk factors here: obesity, alcohol, sedative use at night, being a man, tobacco use, and then structural abnormalities of the uvula or soft palate. And obstructive sleep apnea during sleep, the base of the tongue will completely occlude the airway at times. The patient will be apneic for a period of time. The PCO2 will build up, and then the PO2 will go down. And once the PO2 reaches a certain threshold, your brain says, hey, wake up, you're not breathing, you're not getting enough oxygen. So then they have a compensatory hyperventilation. They have wakefulness that interrupts the sleep cycle, and the cycle repeats over and overnight. On examination, you can see Malampati 3 or 4 airways in these folks, and this is a laryngoscopy view of grade 3 and 4 airways that you can also see when trying to intubate people with these big tongues and full oropharynxes with redundant tissue, which is often not only just the tongue, but adenoid tissue, tonsillar tissue, and just soft tissue from the side of the oropharynx can all contribute to airway blockage. I specifically don't talk about central sleep apnea in this lecture because it's really complicated and is not pertinent to restrictive lung disease. But keep in mind that that's on the differential and often co-occurs with obstructive sleep apnea. So somebody with sleep apnea, every single night when they're sleeping, they have these fluctuations in their PO2 and PCO2. So they have intermittent decrease in oxygen delivery. They end up with endothelial dysfunction syndrome, which leads to vasoconstriction, thrombosis, and inflammation. So a hallmark of patients with untreated, uncontrolled sleep apnea is an elevated CRP, other elevated acute phase reactants, hypercholesterolemia, and these are really contributors to the metabolic syndrome. And sleep apnea, when treated, can actually cause decreases in cholesterol, decreases in cardiovascular risk, all across the board. So this is a very common and very serious yet easily treated syndrome that can really add a lot of quality and quantity of life to your patients when identified early. Granted, the mainstay of treatment is weight loss and exercise. Good luck. But fortunately, CPAP can help alleviate some of this vicious cycle of fluctuating PO2 and PCO2 that leads to the downstream effects of sleep apnea. You have an increase in RV afterload. These folks often end up with pulmonary hypertension from obstructive sleep apnea. And then the frequent arousals not only disturb sleep architecture, but cause sympathetic activation, parasympathetic withdrawal, because you wake up, you say, I can't breathe, panic, tachypnea, 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 leads to hypertension over time. And then abnormal changes of transmural pressure from the pulmonary vascular bed can actually increase left ventricular afterload as well and play into the development of chronic hypertension through the renin-aldosterone angiotensin system. So everything is connected, and it seems like not in a good way, right? That's too bad. So chronic effects here of sleep apnea, you get your hypertension, insulin resistance, and dyslipidemia. You add your central obesity to that, and then you've got chronic vascular disease and strokes, heart attacks, peripheral vascular disease, pulmonary emboli. And on the other side, you get your pulmonary hypertension, progressive right heart failure. If you add a PE onto your pulmonary hypertension, you can get decompensated right heart failure or choropulmonale with cardiogenic shock. So the importance of treating obstructive sleep apnea, not only treating, diagnosing it, recognizing it, cannot be understated. And Mr. Pickwick works in two ways to create his chronic hypercapnic respiratory failure. The increased mechanical load from obesity and leptin resistance lead to a blunted ventilatory response. He doesn't really get too hypoxemic unless he's quite bad, so he builds up the CO2. And then from the sleep apnea standpoint, you have bicarbonate retention and this chronic compensation for the hypercapnia. So the motivation to actually breathe to correct pH goes down in these patients. So when they can become quite hypercapnic and not have any additional respiratory drive, and that hypoxemic drive is what is needed to kick in to normalize the pH and the PO2 temporarily. The end result, all of these equations and things. So respiratory failure, hypercapnic, and hypoxemic, usually in a chronic setting. Screen every single one of your patients in clinic for sleep apnea. I don't care if you end up with a 18-year-old female that's skinny. Screen them all. You know, you don't want to miss this. And obviously the patients that you have a higher suspicion, you may want to dig deeper. If they're not reliable historians, send them for a sleep study. You find things. Any questions about that? Great movie. Great movie. Mainstay of treatment for respiratory failure for restrictive lung disease is positive pressure ventilation. So if they have an acute decompensation, that guy is very serious. It's kind of holding the tube and the laryngoscope funny, so I hope he gets that airway. And then chronic, this guy is like totally chilling with his stylish nasal pillow CPAP, reading a book there. His wife is sleeping because he's not snoring. So, you know, people with all kinds of restrictive lung disease, the entire spectrum, in positive pressure ventilation at night helps prevent that chronic hypercapnia from occurring. And underlying disease management often requires referral, whether it be to a sleep specialist, to a pulmonologist, somebody to fix the spine, or what is rheumatology? We don't know. It's like that insane clown posse song, right? How do magnets work? So if you suspect that your patient has restrictive lung disease, screen for sleep apnea and get your chest x-ray, your full PFTs, and an oxygen assessment, and that can lead you to the appropriate referral. If you're feeling spicy and have a good, you know, clinical exam and suspect rheumatologic disease, go ahead and send off the screening labs early, because when your patient lands in the rheumatologist's office, they'll have something to work with. And 2 to 4 week outpatient follow-up with these patients that you're sending for this kind of testing, because they're probably going to need additional testing to get to the bottom of things. Echocardiography is something else to throw on here, just because chronic interstitial lung disease and hypoventilation can have an effect on the heart. Most often, you'll see pulmonary hypertension or diastolic heart failure associated with these diseases. Always cats. Mm-hmm. Yep. Mm-hmm. So the ones that present with morning headache, daytime somnolence, of that group globally, 80% of them are Mr. Pickwick. 20% are not. But in the 20%, you may go down a wrong diagnostic path and send them for a head CT or something. You have to have a high index of suspicion for the sleep apnea. For all comers, I'm not sure what the data is, but I would say if you have a man over 30, screen him. Yeah. If you have a man over 30, screen them, because those are the people that, especially if their BMI is over 25. Because, you know, we get used to looking at Americans and we see people with BMIs of 30, it's like, they're not too big. Right, I know, like this is nothing. He's a healthy man. He probably lifts weights, right? Yeah. So I don't have an exact answer to your question, but high index of suspicion even for people without Mr. Pickwick. All right, well, thank you guys.